Well, good morning, everyone. I am Dr. Laura Leacher, and welcome to today's Medical Grand Rounds. We'll go ahead and get started with a few reminders and logistics, and then introductions for today's very special talk. Next week, be sure to join us for the talk Vitamania, Regulation, Data, and Consumer Choices, given by Dr. Craig Williams from OHSU. Grand Rounds is a joint effort between Providence St. Vincent and Providence Portland Medical Centers. We are always available, just like today, on Teams Live for a broad viewership. We are often available in person on Tuesday mornings at 8 a.m. at St. Vincent and occasionally in person at noon on Tuesdays at Prov Portland. You can earn CME credit by watching live virtual, live in the room, or a recording of the event. Each week, the Grand Rounds invite will let you know if we are meeting in person and also has the link for the video recording. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions, and I will mostly hold those until the end of the talk to ask as time permits. And now for introductions. We are delighted today to be hosting our 2025 Donald E. Olson Memorial Lectureship. This lectureship was established by Dr. Olson's wife and children as part of his legacy at St. Vincent's, where he led the Department of Medicine for 41 years. Among the early pulmonologists, he began his career at the Portland Clinic and was also professor emeritus at OHSU. He was also founder of the Oregon ACP chapter. Dr. Olson's dedication to medical education at every level was truly exemplary. In the words of his physician colleagues, he had this wonderful humility and sincerity and continuous quest for knowledge that immediately bonded him with his patients. And it is in his honor that it is very fitting to welcome and introduce today Dr. Tracy Henry, an internal medicine physician in the Division of General Internal Medicine at Emory University, where she provides primary care to low-resource populations in Atlanta, Georgia. She's an attending physician for the inpatient teaching services at Grady Memorial Hospital. Dr. Henry served recently on the American College of Physicians Board of Regents and as the national chair for the ACP Council for Early Career Physicians. Currently, she serves as ACP's delegate to the AMA House of Delegates, the Board of Joint Commissioners, and was appointed by the AMA Board of Trustees to the AMA's Council on Legislation. Additionally, Dr. Henry is the chair of the Society of General Internal Medicine Health Policy Education Subcommittee, co-chair for the SGIM Health Equity Commission, and the Associate Program Director for the SGIM Leadership in Health Policy Scholars Program. Wow. Dr. Henry, it is a tremendous honor to welcome you to join us today.
Thank you so much, Dr. Leacher, and for the warm introduction and the opportunity to discuss such a timely topic, and that's physicians' role in countering misinformation through advocacy and action. So my objectives today are to define misinformation versus disinformation versus malinformation, describe the psychology behind misinformation, review the physician's role in countering misinformation, and then discuss steps by level of advocacy that physicians can take to combat misinformation in medicine. So reflections and also a bit of a temperature check. In these uncertain times and politically sort of turbulent and unprecedented times, the role of physicians really extend beyond the confines of our exam rooms and hospital walls. We are called to be advocates. We are called to be purveyors of the truth. We're called to be protectors of science and champions of humanism. And so advocacy is merely not an adjunct to our profession, but it's really part of our covenant with society, a part of our covenant role, and is central to advancing humanism in medicine and also countering misinformation, which is often rooted in bias. So I also like to call your attention to the power of purple. And what I mean by the power of purple, well, I've really been reminded lately of what it means to be a physician leader, what it means to be an advocate, not only for myself, but for my students and residents and colleagues and other co-fellows in our professions and for our patients and in our communities. And so when I think about purple, I think about my sister who died while I was a medical student, who was awaiting a kidney transplant. Purple was her favorite color. I also think about an artist of mine that I really enjoy, Prince. And then, but it also is the color that's most associated with this particular book that I like to call to your attention, The Purple People Leader. And really, the concept of that book was that to be a leader, you have to lead with compassion. And you can't abandon either red or blue. In this country, we think of red, we think Republican, we think of blue, we think of Democrats or conservative versus liberal, respectively. But really, what we have to think about is our role. And thinking about the power of purple, red plus blue equals purple. Where do we find common ground? How can we work across the aisles? And so, like many grand rounds, I like to begin with the case. And so we have a 65-year-old man with a history of hypertension, type 2 diabetes, chronic kidney disease, who presented to the clinic today for follow-up. He is up to date on all of his health maintenance, except you notice that he has not received this year's flu vaccine. And you see that he has declined it during triage. When you attempt to ask him why he declined the flu vaccine, he asks, "Are vaccines really necessary? I've seen on social media that they are not. In fact, my daughter decided not to vaccinate our grandbaby because of all those chemicals in the vaccine that can make them sick." So, what do you say to him? Well, hopefully by the end of the talk, you'll have some words and some ideas in mind. So, for level setting, let's begin with some key definition and terms. And so you've seen a lot fake news, you've seen propaganda, alternative facts, post-truth, misinformation, disinformation. But what does all of that mean? And to really understand these complexities of misinformation, we really have to understand some of these key terms and common languages. And so we hear a lot of misinformation, disinformation, or even the term malinformation. And so misinformation really is that's just where you have these gaps in knowledge. And it could be an honest mistake, for instance, posting an out of date article or guideline. It's something that's contrary to the best available evidence. Whereas you may have something called malinformation, which is basically using factual information based on reality with the intent to harm. And so, an example of that could be sharing footage of real protests. So people really act outside protesting, but ascribing them to an unrelated cause, time, or place in order to mislead, discredit, or create tension. So using factual information based in reality with intent to create harm. And then we have what we call disinformation. Disinformation is to deliberately uh, deliver false information with the intent to deceive. And so that could be an example of politics and election ad. And so there's some overlap. And the overlap really with disinformation and malinformation of both of those has the intent to harm versus misinformation. The intent really was an honest mistake. And misinformation, disinformation, propaganda has always existed. The issue right now is that we have this information ecosystem and that facilitates amplification of that content that facilitates it going viral. So what do we need to consider when we're discussing misinformation and disinformation? Well, we have to think about the intent. Is it the intent to harm, sow division, create chaos? And what is the context? And what is the medium? How is it shared? Is it through social media platforms? Is it through trusted leaders? Is it a scientific journal? And then what is the impact? The people absorbing this information, the number of the results of the action taken or not taking as a result of this information. So how does misinformation work? Well, we have these foreign actors. We have terrorists, we have spammers who take advantage of the internet's fast spreading pathway for information and pipelines for information. They buy bots to spread messages and amplify manufactured narratives and post misleading clicks and shares. What else do we need to know? Well, social media and the industry and governmental policies, their practices towards misinformation and content moderation are rapidly evolving, and that credible information is often complex, is often nuanced and involving and uncertain. And further, the problem, misinformation confuses people because it dilutes the pool of information. And so I think that's the most confusing thing. You could be on a reputable site, or you could be on social media and have something that's mixed in that's true with something that's false. And then you're thinking, well, that's true, so then everything else is true. And so that is a huge problem and difficult for many people to discern. And there are also conspiracy theories. So conspiracy theories actually provide comfort in times of uncertainty and anxiety. And it revolves around our core emotions and values, the mental cues that we use to decide whether the source is legitimate and thus trustworthy. So who benefits from this misinformation? Well, there's really three aspects. There's financial gain, there's political gain, there's experimental manipulation. For an example, the anti-vaccination industry, wellness and nutritional supplement companies, their content reaches 58 million online followers, often through social media, with the cumulative advertising. And so also think about misinformation, you have to think about the left. So should health-related information be regulated? Federal government should provide oversight, and the argument might be made that the government's oversight, because of the wide circulation of false information, can lead to real injuries and harms. And so the government's role is to protect the general welfare of its citizens, but also the government's role is to protect the private citizens' right to free speech. So which one wins? And we think about our First Amendment, which basically says it affirms that private citizens have a constitutionally protected right to articulate personal views and beliefs in public spaces. And we also have commercial speech, for example, advertisements for tobacco, alcohol, and gaming. We have professional speech, which courts really struggle with the professional speech to articulate a consistent approach to define the scope and limitations of states' power to regulate our healthcare professional speech. For example, physician speech regarding firearm ownership and speaking to their patients about the dangers of firearms in a clinical visit. So we know that there's a huge problem, but why aren't we more aggressively addressing it? Well, social media platforms are designed to keep people engaged. Algorithms have learned that sensationalized information and content maintains eyes on it, which means millions, billions of dollars in ad dollars. Other challenges. So, is an authoritative source only an institutionally authoritative source? I think the answer is quite clearly no, but how do we decide what an authoritative source is? And I think that was a huge problem in the height of the COVID-19 pandemic. We saw many people just really unclear who were the respective sources, who do I turn to? And then other challenges is how do you help the public make sense of something when the authorities and researchers are still trying to make sense of it themselves? And so when we have myths or disinformation, it's like a nidus of infection. When we have information and data voids, bad actors to manipulate, that is a source for misinformation to run rampant and viral, so to speak. Then we have the broken clock problem. Just very similar during the COVID-19 height of the outbreak and pandemic, there were a lot of early on people who said, this is going to be a pandemic, and many people didn't believe it. So those folks who said it was going to be a pandemic were right. So all of a sudden they were re-legitimized, and so they said, well, look, we got this right, so everything else we said is right. So it's a bit about the broken clock problem. And other challenges is that can the government develop long-lasting enforceable solutions to the problem of false health information? And of note, I have to point out that there was this group called the Disinformation Dozen, where 65% of the shares of anti-vaccine misinformation on social media platform came from these 12 users. They were on Facebook, they were on Instagram, and what was previously known as Twitter. So social media gateway to fake news is real. A 2017 study showed social media brings more people to fake news sites than real news sites. Greater than 40% of visits to 65 fake news sites came from social media versus 10% of the visits to the top 690 US news sites. And in September 2022, there were 4 US-based NewsGuard analysts that contrasted search results from that were on TikTok versus search results on Google. And 19.4% of the top 20 TikToks contain false or misleading information. So what is the psychology of misinformation? The psychology of misinformation are really those mental shortcuts and confusions and illusions that encourage us to believe things that aren't true. So what can that tell us? And they can really tell us a lot about how to prevent its harmful effects. So vaccine for misinformation, this is from the National Academies of Science, had a meeting and some research and convening of how do we find a vaccine for misinformation. I like to think about 3 key factors when we discuss mis and disinformation, and that's social contagion, framing, and worldview. They really govern how people absorb information, how we form beliefs, and how we modify our behaviors. And when we think about the 3 of those, none of those actually have much to do with objective truth. So social contagion, it's a formal name for people's tendency to think and act like their friends and their family. For instance, smoking or obesity or a variety of other behaviors. It's the adaptive ideology, which is important for self-verification, how we identify with others, with our friends and our family. And so we're more likely to conform in situations where uncertainty is high, especially with what our friends and families are doing and thinking. These behaviors actually spread through social networks simply by jumping from person to person like a virus to virus. Then the second one, another key factor in how messages are framed, is through framing. And those evoke deeper narratives that are already exist inside of our minds. And those are those cause and effect storylines. So if you ever think about things that you remember, or when you tell a friend or you tell a student about a story or a patient story, it's always sort of the cause and effect because those are easier to remember. They're powerful. They can evoke negative, positive emotions. It could be negative emotions like fear, anger, disgust, even when the story is false. And so an example would be a medical expert working for the government found a causal link between vaccines and autism, but federal lawmakers, influenced by the powerful pharmaceutical lobby, helped to bury that information. And so as soon as you hear that and you hear there's a conspiracy and someone burying something, it's structurally coherent, this sentence, and that it's easy to grasp and recall. And so coherent studies work. Our minds just don't encode facts, but events into memory. And so when you hear something like that, you're like, oh gosh, there's someone's, it's a conspiracy, they're doing something. That is what we're going to remember and structurally remember. And that's negative emotion is something that we will keep with us. And so with framing, we store the bottom line gist or meaning. So not just the facts, but the gist of things. And that's what typically guides our beliefs and behaviors. And another example was that a researcher collected 10,000 tweets about vaccines from 2014 to 2017, and he looked for commonalities among the 46% that were retweeted. Those posts that were retweeted had a very strong but false bottom line message about vaccines causing autism. Tweets that contained facts and statistics did not spread very far. Again, things that evoke negative emotions that are sometimes like a conspiracy are easier to remember, and sometimes we hold close as part of our response to hearing the information. And then the third one is worldview. So those are our pre-existing internal stories on our mental views of our culture, our knowledge, our beliefs, our life experiences. And so any direction to correct those worldviews, things that were already internal, that were already have sort of been groomed and learned, that were part of our culture, is very difficult to correct. So if someone says, "Hey, you're wrong, you need to think differently," that's less likely to work because this is something that is a part of ourselves. So correction that contradicts internal narratives can sometimes easily backfire, which means that people will actually hold on to their original information even more strongly than before. So, like in medical decision making in medicine, we all have biases and heuristics. And so, some other biases would be confirmation biases. And that's a tendency for people to attenuate to or interpret information that is consistent with their beliefs. And then the idea is that we have sort of the sweet spot, and we have science and facts, and we have opinions and beliefs, and there's a little bit of the overlap. And this is the reason why debunking doesn't work. And that's really just because if we already have these opinions and beliefs, it's really hard to change even when confronted with science and facts. And then we have these representative heuristics. And so these are the cognitive shortcuts wherein people, where we determine the probability or frequency of an event based upon assumptions of past experiences. They're sort of driven by our need to create automatic cognitive ease and categorize, much like biases that we may carry in medicine. And so an example might be birds. So when we think of birds, you probably are thinking birds that fly, but not necessarily um, birds that swim. And then there's the availability heuristic, and that's another cognitive shortcut wherein decisions are made based upon knowledge that is readily available or whatever is most salient. And so rather than examine the probabilities and other explanations, we really just sort of encode and deal with whatever we see in front of us. So what are some strategies for combating misinformation? Well, we could do something called misinformation inoculation, and that's when we develop belief resistance in people as we develop disease resistance in a biologically overprotected person. So the idea is that we are exposing someone to a small amount of vaccine or small amount of mis or disinformation, so hopefully they can combat it in the future. This sort of immunity of misinformation and to basically pre-expose us to a weaker or weakened counter argument has been around for several decades. And I like this picture because it just kind of shows us the vaccine analogy to inoculation. So we're doing the same thing with misinformation. And so the process of psychological inoculation, you have the vaccine. So we're warning someone of an impending threat. We're warning someone that there's bias, or we're warning someone that there's mis or disinformation. That triggers production of mental antibodies to make us recall that, oh my gosh, someone's trying to dupe me. And then we have a bit of psychological inoculation. So hopefully we build some resistance to future persuasive attempts. And so we also call this sort of psychological inoculation pre-bunking, very similar to the term debunking. So a lot of times we're trying to debunk when a patient comes into the clinical setting, we're trying to debunk and change their minds, which is very difficult to do. So our goal should be to pre-bunk, teach our patients, teach our communities, go into the schools a little bit early on to teach about science and science literacy so that it makes it easier later on when we're taking care of patients or patients are absorbing information in social media. And so pre-bonking, the inoculating requires two elements. So explicit warning about the danger of being misled by misinformation, and then also providing counter arguments or explaining the flaws in that misinformation. So again, it's focusing on prevention, pre-bonking versus debunking. And it's a bit like herd immunity. So it's a herd immunity to informational disorders. And so you may be wondering, is there any studies? Has anyone ever tried this? And so, yes, they have. And so here's one. It was called The Bad News, which was a free online game. And basically, players took on the role of an aspiring fake news tycoon. The task was to get as many players as possible by actively spreading fake news. And when you play the game, you learn 6 common misinformation strategies, such as polarization, conspiracy theories, the use of emotion in media. And so it works because people have to actively reason their way through how misinformation works prior to being exposed to the real version on the internet. So they played around with this game. And so does it work? So this is actually from the study. And this is a violin plot. They tested about 15,000 participants, both before and after playing with the fake news game. And before is the blue, and then post after is the red. So they noticed that there was statistically significant difference for participants in the study to spot misinformation, and they were more confident in their judgment about fake news. And they saw that across all different demographics. So we have liberal versus conservative. You saw that the smaller the violin on the right and the red is sort of the degree of reliability of the difference. So you saw that across political affiliation, we saw it across age, younger versus older, uh, education, and also intuitive versus reflective personalities. There were other studies that also showed some of the similar effects. So there was one about global warming petition project. So basically there was a study to identify the most influential and representative counter messages used by climate change opponents. And basically it came to sort of the same conclusion, is that if you pre-bunk, if you tell people up front that they're being duped, if you start giving if you give patients a little bit of information up front to let them know that things are incorrect, then you're less likely to believe the fake news or misinformation later. And that's basically what we're showing here. And this particular slide, if you go to the third one, so they had the consensus treatment group. So you receive the positive information, but you also see the counter information. And what we notice, if you hear on both sides, it sort of cancel things out. So what you really want, again, is the pre-bunking. So with the third, and where it says LN1 and CM and LN2 and CM, is basically the first one, they had a little bit of dose of misinformation. And then the second one, more of misinformation, was told more things were fake up front. They were less likely to believe the misinformation. And so read it with that here is where, and LN2 is where we want to be with our patients. And so it turns out the key to stopping science denial is really to expose people to just a little bit of science denial. And what we also know is a lie gets halfway around the world before the truth has a chance to get its pants on, and that was Winston Churchill. So what can we do about it? We know about the problem, we know about the challenges, and we know some studies that have been conducted that were successful. And basically the gist of those is that you have to teach people up front. No one likes to be duped. So the physician's role. Who is responsible? During this time, some people say maybe it's the tech companies. They're the ones who own the social media platforms. They're the ones who are allowing such information to exist and malign distribution of content. Others may say it's our role or clinicians' role or other health professionals' role. And so I would say it is part of our professional code. It's part of our code of ethics to actively participate in conversations about health, and to help correct false or harmful information in virtual public spaces. And also in the 2022 Gallup poll, medical doctors were still falling behind. We're still pretty high in the poll of respected profession, and so people do still listen to us. And then I guess the other really question that's not clearly straightforward is it our professionally or ethically appropriate to attempt to correct and redirect patients when you're seeing things or they're doing things outside of the clinic or exam rooms? And I think that's more of the question that is not as straightforward. Is, if it happens outside of the clinical setting, do we really have a role? Because it's outside of our individual patient-clinician relationship. And so our call to action. This is the sociological framework with examples of misinformation by constructs and by level. I like to use this is because many of us, when we think about advocacy, sometimes we think that's going to the Capitol, that's going to the Hill, that's doing something legislative. And advocacy really can occur at many different levels. And it could be the individual level. It could be what we do between us and other people or in our institution or community, or if you so choose, legislative or national level, but we really have to choose what's right for us, what's within our own sphere of influence. So not expecting you to read all of these things, but these are examples of things that can be done to address misinformation at multiple levels. So we'll start at the national legislative level. So over the years, there has been tons of legislation that has been introduced into Congress that has not passed, but basically it's basically to address misinformation. How do we do it? How do we address that dilemma to protect the rights of free speech, but also protect the health of the public? So what do we do there? And some ideas have been around having cross-sector collaboration across multiple domains, tech, science research, medicine, et cetera. How do we bring all of those conveners together to come up with a way to best address this? What laws should be in place? And so there's no one, consensus on that, but actually having a committee, some research could be helpful in figuring those things out. We know that the American Medical Association also adopted a policy aimed at addressing public health disinformation. The Federation of State Medical Boards also declared a statement stating that physicians who knowingly spread demonstrably false information risk suspension or revocation of their medical license. And other several boards, including ABIM, have also supported this position. And then what's controversial is that state legislators are considering or have passed laws prohibiting licensing boards from taking disciplinary action against physicians who spread misinformation or prescribe unproven treatments. And we also saw within the last administration, there were some ways, there was a report on medical misinformation by the Surgeon General on what health professionals can do as well. Things we could do in our community, not under reassuring people, providing numbers, context, history, working with community organizations, partnering with communities, having fairs, walking, being available, volunteering, being available as a trusted source in your community to answer questions about things that are going on in the news or pandemics or public health issues or crises, so that patients can see a face and have an actual person to talk to and not simply a bot on social media. And some examples, going back to COVID-19 pandemics, so we did similar things like this. I was a part of several community town halls, met people where they were. Lots of people are on Facebook, so we had lots of things on Facebook for patients. Dr. Vinny Awara did quite a bit of work with the Illinois Medical Professional Action Collaborative, and also working with community organizations. There were other community groups. Dear Pandemic, this was 9 self-described nerdy girls with all PhDs in health and science. And they also took to the streets, so to speak with folks in their communities about mis and disinformation. So from an institutional level, if our goal is to impact our patients and outcomes in public health, we really need to meet the patients where they're getting their information. So one particular person, Austin Chain, who was at Jefferson, and what was really interesting about him is that he became the clinical liaison to media relations team there. So he worked with the community, but also had started something called a chief medical officer role of AI and mis and disinformation. And so with an online presence, he was able to be medical social media officer, really working directly with people, figuring out where people are getting their information and directing them to the appropriate places for correct information. the social media, the Association for Health for Social Media advocacy group as well. Another place that's super important is where we read our information. So JAMA also came out early on with the role of how do we counteract health misinformation, and what is the role of medical journals. And so, again, this is something that they recommend that we really get out, that science literacy should start early on. It should start in primary and secondary schools and our educators, so that we are developing a community, or we're developing a nation of folks who know how to discern between real information and mis and disinformation, and have science literacy. And other things that some other institutions are doing, for example, University of Chicago Pritzker, they started the SIFT, which is stop, investigate the source, find trusted coverage, and trace the original context. So that's one of the courses that they teach in their medical school, and it's order to help empower healthcare professionals and share strategies with their patients. And then there's the interpersonal. This is what we do in the clinical setting. I always like to say, lead with your why, follow it with facts, stay calm, educate your patients, but really acknowledge your patient's fear in the clinical encounter. Use facts, but don't lecture. Build on those relationships. Focus on shared goals. Again, if you challenge someone's internal core beliefs, it could backfire. They'll hold on to it more strongly. So you have to meet patients where they are. And then this is just other language that you can use. I always find it's very easy to talk to people if I've sort of practiced that language or have a schema. And so you might say, I don't see the things that see the way that you do. I see it as blank. Or, for finding common ground, you might say, well, we don't agree on this, but we can agree on blah, 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 such as safely reopening schools, or maybe medicines can help. And even more specifically, vaccines could also help. And then also think about engaging with empathy by providing a personal story. You might say, oh, I remember that time I shared false information on this social media platform before I realized, oh, I should have read to see and verify that information first. And then so finally, individually, there are lots of things you can do, reaching out, through op-eds. You can write about some of the problems some patients do. There are a lot of people still read the newspaper. There are a lot of people go online for their news and other trusted sources. And so you can sort of be that individual person and face by writing about the problem and also solutions. And so solutions could be, invested in media literacy education. It's improving existing fact-checking mechanisms. It's passing legislation against creating and spreading fake news or deliberate, I would say, disinformation, which is the deliberate spreading of false information. And then how do we adjust algorithms to disincentivize deceptive content or develop new ones to detect it? So there's no one single solution. We really has to be a cross-sector collaboration, and it's going to take a team to do it. So back to our case where we had the 65-year-old man who came in for just a routine follow-up, declined the flu vaccine, and really had some questions and didn't think it was necessary. And so, what do I say now? Well, you have to sometimes, you unfortunately, sometimes with some patients, you really have to think about how you can speak with your truth and lead with empathy. I point, do you want to, what is sort of your endpoint, or who's important in your family? Who do you want to see? Do you have a grandbaby? Do you want to be around to see the grandbaby make it to kindergarten or their high school graduation? And things that are really easy to do would be like taking a vaccine for flu to keep you out of the hospital. And so, politics aside, social media aside, people die from the flu, and I know that the flu's vaccine will help to protect you and keep you safe. And vaccines for children are safe as well. And so there's multiple different avenues that you can take, but really just start by, answering his question, validating sort of, some of his thoughts, but also moving forward to how he can better protect himself. And so pulling it all together, inoculation or pre-bonking cannot be the only solution. It could be the first line of defense, though, but there should be cross-sector collaboration, computer science, tech, behavioral medicine, public policy, and physicians. We play a pivotal role. We have to stand with science. And remember, we have to embrace the power of purple. And that could mean, that means for us as physicians that we are practicing compassion, and that compassion really can transcend political affiliations. It involves listening actively, understanding diverse perspectives, fostering unity in our advocacy efforts, and we can lead effectively and inspire collective action toward common goals. And so recap, we went through the 3 types of mis and disinformation, the psychology of it, what our role is, and review some examples. So in a pandemic, the strongest attractor of trust shouldn't be confidence, but the recognition of one's limits, the tendency to point at expertise beyond one's own, and the willingness to work as a whole. Here's my contact information. Healthcare is not so easy. Thank you.
Great. Thank you so much, Dr. Henry. And delighted that we have some time for questions and comments and conversations. So I'll go ahead and get us started with some ideas online, and please feel free to continue to post, those of you out there in our audience. This is a general statement from one of our participants that I'll let you reflect and build on, Dr. Henry. They say, it appears that our job has become much tougher in countering misinformation, since misinformation is now being passed on to the public from the top levels of our current US government. Any thoughts where we stand in this process with the current situation?
Yeah, again, just sort of going back to the presentation, I think we really do have to stand with science. I think that's it's time for us to really sort of get involved with our professional homes, because if we're extremely busy clinicians, researchers, educators, we can't take off daily to go to the Capitol or go down to our local Capitol to sort of speak with legislators. But what we can do is sort of lean in together as communities in our professional homes, and have our and advocate through those professional homes to let legislators know, let the administration know that we do stand with science, and that is the only way forward. Patients first. We're patient-centered, and so we have to do what we know is right for our patients.
Yeah, great. Thanks so much for those thoughts. And I think sometimes it is difficult, like in our busy everyday lives, to know in this landscape what do I actually do. Dr. Henry, introducing you, seeing you involved in AMA, ACP, SGIM. Could you speak just briefly to those of us out here who may not be as involved in some of our available organizations? Just a couple words on your experience with that. How might a person get started?
Oh, yes, of course. So, get involved in those organizations are really easy. You can go to the website, you could talk to a colleague or friend in your clinic or your hospital system that are a member to hear more about it. But literally going to the website, getting started, joining. SGIM has regional conferences where you can meet and collaborate, network, but also attending the national conference is a great place to get involved. And if you join SGIM, emails that come out pretty regularly on joining various committees and joining and becoming a leader. So it really starts with just volunteering. I say the same thing with AMA. You pay your dues, you join, you attend the meetings and get involved in the resolution process, the House of Delegates making policies. A lot of legislators listen to the AMA, so getting involved, being at the table, influencing their policies. So they take those policies to influence people in the government. And then again, with American College of Physicians, which is also one of my professional homes, again, you join there. I love that most of every state pretty much has a chapter, so you can get involved. Some states have two or three chapters. And so you can get involved locally, but you can also get involved nationally as well. And attending their meetings, attending the chapter meetings in ACP is another way to get involved in joining committees. And I think that's really where I got my start. It's just going online, joining all of these organizations, joining the local organizations first, getting involved, being active, and then, also that led to other leadership roles nationally.
Great. Thanks so much, Dr. Henry. It was interesting and exciting to notice in the introduction that indeed Dr. Olson was the founder of the Oregon chapter of the American College of Physicians. So that's a great local opportunity that I'd certainly encourage people to check out and get involved with.
Yeah, and I would say there's something for everyone. And even if it's a committee that you're not interested, there's not a committee that you think that you would be interested in joining, you can also talk about creating that committee. Like every one of those organizations will love to expand and reach the needs of their membership.
Great, absolutely. Here I'll reach back into our comments. Dr. Henry, what a timely and helpful talk. I have already shared with several family members. What advice do you have for those of us with family who firmly believe misinformation, particularly with regard to young people? I'm wanting to avoid appearing to not respect what their parents are telling them while opening up the possibility of a scientific viewpoint. Any comments for people close to you, and maybe particularly when speaking to those younger than ourselves?
Yeah, it's challenging. Again, if they're younger, you think about so we tend to hold on to things that are a part of our internal worldviews. However, there's the idea of social contagion that I talked about earlier, that we believe what our friends and family think, and it spreads like wildfire. And so I think there's some space in between there, that if it's a family member that's holding on to misinformation, there might be some area of the idea of, I'm kind of like not like the others, and why do they believe that? So you may approach that very gently, very much like sort of motivational interviewing. You may just say, hey, that's interesting. So why do you believe X, Y, and Z? I know you said you saw that when you Googled, or you saw it on social media. Okay, but I also Googled this on social media. So who's right? And then you kind of open the doors, and if, maybe somewhat logically you might go, well, we both Google which one's right. And then that may be open doors to sharing some of that information. Again, debunking is very, very difficult, which is why I really spent a little bit of time talking about the pre-bunking. But I think if you just sort of ease into the conversation, more frequent approaches and touches versus forcing it, because if you force it, they're going to hold on into the information more closely.
Mm-hmm. Yeah, I find that to be such a challenge in approaching these situations, to avoid kind of digging in deeper. Important to think about. I have a slightly different direction question for you. I think for all of us working within the U.S. healthcare system, we certainly do every day see examples of profit-driven influence in healthcare. And I wonder a little bit if you have any ideas or talking points, or even just your own perspective of sort of building trust among our patients, and balancing that nuance of there are reasons to be skeptical of the healthcare system.
Yeah, so our American healthcare system is not perfect. I think we can all agree on that. And it's okay to have those conversations that it's not perfect. And it's okay to say, in an ideal world, everyone will have act to the healthcare that they actually need at the right time, safe, quality healthcare. But you can also say with your patients, and that's our goal here in the clinic visit, is to I'm here to help you along with social work, along with other members of our team to make sure that you get the right care at the right time. But yes, healthcare is very expensive. It's okay to say that we spend a lot, we spend the most of any developed country on healthcare. Those are facts. We spend 18% of our GDP on healthcare. Those are facts. So things are profit driven. And it is broken and dysfunctional, but you can also say that. But my goal is also to make sure you get the right care. My goal is also to advocate not only for you here, but I'm part of an organization that advocates that we make some change so that we can have a better functioning, working healthcare system.
Mhm. Yeah, thank you for those thoughts. Another comment and question, often in healthcare, and particularly the public health space, when we have success, it often means that a bad thing never happens, right? So you get a vaccine, nobody gets sick.
Mhm.
Can you help us think about ways to celebrate or create narratives around success when success is that sort of nothing happens? Any thoughts on
Yeah,
that?
yeah, that's a really great question. I think you have to highlight your successes. I develop a curriculum back in my home institution, and every year we sort of make changes based being proactive. Also, when we make changes based on what students previously said, but the new students don't know we made those changes, and they never know that we started way over here and we ended up over here. And the same with like measles, right? It was eradicated over 20 years ago. So I think we have to start celebrating our successes in a public health way. I think a lot of things has to do with messaging, and I don't think a lot of people didn't know that measles was eradicated until they started seeing the cases back again. And so we have to, the same way we have other messaging in the public messaging that we no longer have. We For a while, smallpox or measles, all those things were eradicated, and we have to start saying that we have to start messaging it. It should be on social media. It should be on all the different platforms, the Facebooks, or if you Google it, or the TikToks, the Instagram, the Snapchats. And I think that's really sort of the way forward so that we don't forget and it becomes back of mind and the next generation takes something for granted of why we did not see measles and why we're seeing measles now or any other pandemic that we've eradicated.
Yeah, thank you. Um, well, thank you so much for your time. One parting comment and question. You gave us really a spectrum of things to do or think about doing from the individual up to the national level. One parting message or your most passionate, do this one thing next. Any parting advice for us, Dr. Henry?
Oh gosh, I would say I think I think we all have to speak up and speak out. So if you see an injustice, I think you have to correct and fact check in the moment. You can't wait and go, I'll pull this person to the side and tell them. I think we have to start addressing it in the moment when something's untrue, if it's mis or disinformation. So I think just being a little bit more emboldened in a nice way, but really start to let people know when something's not true. um, we have to say something and do it in the moment.
Great. Thank you so much. I intend to step bravely out from this grand rounds and see where I can influence my community. Thank you, Dr. Henry. Really appreciate your time. What a tribute to Dr. Olson.
Thank you so much.